Infectious disease is a very big and broad topic. Throughout the different segments in infectious diseases, what I'm going to focus on is specific infections and oftentimes sites of infection, and basically trying to teach you which bugs may cause an infection. And along with the bugs that may cause an infection, that's going to lead us down the path of which medications would most likely cover those bugs, and obviously that type and or site of infection. So this is primarily going to be bacterial infections. I maybe got a couple of viral infections in here, but certainly check out the fungal and viral infections as well. I'll talk about those more in that specific section of the webinar. So again, multiple disease states I'm going to talk about here, multiple different types of infections, and let's get going on it. So first off, sexually transmitted diseases, lots of different bugs that can cause STDs. So with STDs, chlamydia is a real common sexually transmitted disease. Uniquely, chlamydia tends to be more asymptomatic, where patients don't necessarily present with any problems, especially early on. The challenge with that is that easily helps the spread, so to speak, where patients don't feel sick, they don't feel any concerns, no burning, no symptoms in the area, and that transmissibility greatly increases there. As the kind of disease process takes hold and progresses, certainly burning with going to the bathroom, sexual intercourse, itching, discharge can happen, which can obviously be somewhat concerning to patients, and those symptoms may bring them in to get assessed. In the long run, if chlamydia goes unchecked, untreated, it can cause in females pelvic inflammatory disease, or PID, and this can lead to a situation where it leaves a female patient infertile, where they're unable to have children that way. So longer term, as that disease hangs on, as that infection hangs on without being treated, that's problematic, certainly. Treatment, azithromycin, and 1 gram single dose is actually what's used here, and in most situations that's going to be the drug of choice. We've got easy adherence, we know they're going to take it. Oftentimes we'll look at potentially treating partners and things of that nature too, so that's important to remember, think about, ask. Doxycycline is an alternative if for whatever reason patient's intolerant of Zithromax. Doxy remains an alternative. Gonorrhea, so the bug there, Neisseria gonorrhoeae, again, there can be some patients that may be asymptomatic here along with the chlamydia. There may be a high rate of co-infection risk, and certainly both those infections can potentially contribute or cause pelvic inflammatory disease, leading to, again, infertility in females. Management, treatment, so oftentimes you will see dual treatment of chlamydia and gonorrhea together. And what is typically done is azithromycin plus ceftriaxone. Okay, so that's a common situation, oftentimes done in the clinic, so we don't have to worry about adherence and different things that way. And then, of course, that reassessment of partners and treating them, managing them accordingly as well. Now, syphilis is a little more complicated. So the bug is Treponema pallidum, and there is multiple stages to syphilis. Syphilis is usually pretty easily treated upon recognition and identification that that's what a patient has, and we simply use penicillin antibiotics. But If that, for whatever reason, patient doesn't come in, they don't recognize this as a problem. Syphilis has multiple stages, and as we get into more later term significant stages, there can be severe consequences. Again, most patients are probably going to recognize something's wrong and something's up and come in and get checked out, particularly if you've got, a sore on the genitalia or things like that. People will likely notice that. After that kind of initial sore that appears, patient might be feeling pretty normal, that type of thing. Then they may start to feel a little bit sicker. Fever, lymph nodes, and maybe not feeling so great. If they still don't come in, don't get treated, there may be an asymptomatic or a latent type stage. And then after that, there's a tertiary stage, which can lead to CNS, neurological problems, also impact cardiac function in the long term. So, again, drug of choice, penicillin antibiotics for syphilis. Genital herpes, so this is a viral type infection. So, most often, the STD portion of it, the genital warts portion of it, or genital herpes portion of it, is caused by the HSV2 subtype. Antivirals for outbreaks, I think that kind of makes common sense. So acyclovir, valacyclovir, and so on. Many times patients who I've seen that have, periodic outbreaks and that type of thing, they'll just have a kind of long-term prophylactic type agent available where they're given a script, for 14 days, 21 days, and that's going to last them the year, and they understand to only take it for 10 days as they get an eruption of that, reemergence of that viral infection. If you get a patient that has, very frequent episodes, frequent outbreaks, sometimes you will see patients on once daily or something like that, antiviral therapy in the long term, every day, indefinitely. And definitely recommend patients avoid sexual intercourse, sexual contact, when we've got potential signs and symptoms of an eruption and or prodromal symptoms, which may represent that an eruption is soon to occur. HPV, so this is more on the genital warts side of things. I think I misspoke there in the herpes section. Some of the agents that you'll see used here are topical agents. So Eldera cream is something I have seen used. We may try to do some surgical things and use some acid-type agents to remove those warts and manage those warts that way. So there is a few different things we can kind of do with those depending upon severity, effectiveness, what's tried, and so on and so forth. Very, very important to remember that Gardasil is a HPV vaccine. Okay, so definitely encourage patients to get this, to take care of this, and it does protect against some of these strains that cause genital warts, as well as the cervical cancer piece that can be caused by HPV. Bacterial vaginosis, another usually sexually transmitted disease, so caused by Gardnerella vaginalis. Oftentimes it can be due to floral changes, which allows kind of that excessive overgrowth and, killing off those regular bacteria that are normally there. Also, you may see it if there's alterations in estrogen. Remember, estrogen's that hormone that kind of helps establish and keep that flora normal and regular. If we've got alterations there, whether that be through medications, whether that be through life changes in the female cycle, that type of thing, that could potentially impact and increase risk of bacterial vaginosis, or sometimes called BV. With BV, there's a discharge and usually a distinct odor associated with that infection. And drugs of choice, metronidazole and clindamycin. Definitely two to remember there. Trichomoniasis vaginalis is a protozoal type infection. Again, kind of similar symptoms. And again, these are all, done by testing and figuring out what exactly is causing the symptoms. We can do lab testing to figure that out. Again, metronidazole is used there. Tindazole is also a potential option in the event that flagell is not effective. Now, getting into surgical antibiotic prophylaxis. You have to, when you think of surgery, you have to think of the site, the location that surgery is happening, and what potential bacteria may be involved, maybe around that area. So oftentimes in surgery, we're obviously going through the skin. So our first look, the first thing that I think about is staph and strep, which are kind of commonly found on the skin, and potentially as we enter to do a surgery, that's a potential bug that may, or bug or bugs that may contribute and or cause an infection potentially. So using skin as those targets and targeting staph and strep, often you'll see a drug like cefazolin IV used to help prevent infection or used for antibiotic prophylaxis. Another option, ampicillin. Again, good gram-positive staph and strep coverage. Now, in the setting that we're at risk for MRSA, so methicillin-resistant Staph aureus, we may have to think about using something like vancomycin for antibiotic prophylaxis. If you've got somebody that's allergic to penicillin, cephalosporins, and those type of agents, we may see clindamycin used in that setting. Now, GI surgery, we have to think more and more about gram-negatives. There's a lot of gram-negative bugs within the GI tract. We also have to consider anaerobes, so metronidazole, clindamycin, always an important test question, or a test question I've seen come up. These have decent coverage over anaerobes. Gram-negatives, quinolones generally have really good coverage there. Oftentimes, other drugs that have really good gram-negative coverage is the aminoglycosides. Now, oftentimes we don't use those quite as much because we do have maybe some risk of ototoxicity and then monitoring levels and some of that stuff too. So that can complicate decisions. But oftentimes for a GI type surgery, you may look at gram-negative coverage with quinolones and anaerobic coverage with metronidazole or clindamycin. Urologic, so we have to remember which drugs cause urinary tract infections, and that's often gram-negatives like E. coli and the rest of those bunch. Antibiotics there, again, what do you use for urinary tract infections? Bactrim is a very common agent used for UTIs, and in the event of maybe more severe UTIs, quinolone antibiotics as well. So again, recognizing that location. Now, with urinary tract infections, let's kind of flow into management and treatment of UTIs. As far as the definition of a urinary tract infection, it is defined as at least 100,000 CFUs, or colony-forming units per mil, in a pure culture of avoided clean catch urine. And in men, those bacteria are much, much less common. So that threshold is obviously much, much lower there. But again, in UTIs, you have to remember, particularly in geriatrics, these are really, really hard and challenging to diagnose sometimes. And that is a big, big challenge. And I would say from a pharmacist perspective, not a physician perspective, from a pharmacist perspective, we really want to try to make sure that these patients, particularly females, have symptoms and that we're not treating asymptomatic bacteriuria, where that's basically patient doesn't have any symptoms, but they do have bacteria in the urine, because that is common, or certainly can happen in our elderly patients. So there's that asymptomatic bacteriuria where we've got the bacteria in the urine, but we don't have any symptoms. So in that situation, hopefully we aren't really checking a urinalysis and checking a urine culture and assessing for bacteria if we don't have any signs or symptoms of infection, like fever and flank pain and dysuria, painful urination, things like that. We do have a definition for recurrent UTIs. So if patients, obviously having more than 3 UTIs in a year or greater than 2 in 6 months, that's classically considered as a patient with recurrent UTIs that may warrant antibiotic prophylaxis in the long term. Other terminology, I don't think that's incredibly important for you to remember as far as that goes, but I would say keep an eye on those geriatric patients if you're asked a case about that, and making sure we're not treating patients without any symptoms, signs and symptoms of infection. Those common bugs, E. coli and a few others there, Proteus, Klebsiella. Staphylococcus is a gram-positive. Generally, when we think of UTIs, E. coli is by far the most common one, and it is certainly gram-negative. Antibiotics, Bactrim, I've mentioned, nitrofurantoin. Remember, you can't use nitrofurantoin if we've got some systemic and or kidney involvement, because it doesn't really treat a kidney infection. It treats, infection in the bladder and the urinary tract. Cipro and other fluoroquinolones, we probably try to reserve these if we can. We've maybe got a few more risks of adverse effects and outcomes there, drug interactions, than we do maybe with Bactrim and nitrofurantoin. Fosfomycin is another one that is used in UTIs, but not very often. And third-generation cephalosporins, you may see like a Rosef and ceftriaxone used periodically as well. Again, they're going to have decent gram-negative coverage, certainly. But with that, as we start using the quinolones, third-generation cephalosporins, you get into maybe using some of those bigger, broader spectrum agents. So some common regimens here. You can see the Bactrim and trimethoprim, quinolone antibiotics, nitrofurantoin, and most patients, if it's not an uncomplicated, or if it is an uncomplicated situation, maybe a younger, healthier patient, we may only do 3 to 5 days in that range of an antibiotic and try to get them through that infection. Now, as you get to more complicated cases, maybe systemic involvement, if patient's got a sepsis type situation, it's probably a hospitalized patient, obviously. But yeah, as they get more complex, we might tend to do a little bit longer regimen. And so here's some of the things that might lend this infection more towards a complicated status. So diabetes, immunosuppression, transplant patient, kidney disease, and any type of structural abnormality. So if you hear a patient's had multiple urinary tract surgeries, issues that way in males, if we've had urinary retention, prostate surgery history, that tends to lead more towards a complicated type infection. And so there, we're maybe going to use some of our bigger, heavier guns or bigger type agents potentially, and a little bit longer course of therapy likely. Now, inpatient management, again, Rosefin I mentioned, potentially ceftazidime if you've got some Pseudomonas type involvement. Aminoglycosides have a great gram-negative coverage, so they can be helpful in managing UTIs, but we certainly got to remember the risk of ototoxicity and nephrotoxicity. If we've got extended spectrum beta-lactamases, we may end up using carbapenems, which are kind of one of our biggest guns that we have potentially in the management of really significant UTIs and or highly resistant bugs. Prostatitis, kind of staying on that flow of the urinary tract or in that region, the genital urinary type issue or areas. We've got prostatitis. So symptoms of prostatitis: pain, inflammation, change in that urination. You might be blood, you might have more frequent, you might have smelly type urine, that type of thing. And with prostatitis, that specifically, the definition is inflammation of the prostate, and that can be due to multiple things. But obviously, in this section, we are talking about bacterial infection. So if we've determined it is bacterial infection, simply remember the drugs that treat UTIs. And one of the big differences, so the drugs are pretty similar between UTIs and prostatitis, so that's a good way to kind of lump those together. However, prostatitis is a more difficult infection to treat, and so we often extend that length of therapy. With bacterial prostatitis, chronic bacterial prostatitis, you may see possibly up to 12 weeks of treatment using quinolones, Bactrim, potentially doxycycline could cover as well here. So again, UTIs generally an acute type situation, and we're going to use shorter courses of therapy. Bacterial prostatitis, 6 to possibly up to 12 weeks in some instances might be required to help treat that type of bacterial infection in males. Adjunct symptom treatment, pain relief, yeah, certainly that's kind of a no-brainer. I did want to mention urinary flow. If patients got inflammation of that prostate and they're having difficulty with urination, painful urination, an alpha blocker in that setting could potentially help with some of those symptoms. Now on to GI infections. So two classic infections are C. diff and H. pylori. I think you definitely have to remember both of these very, very highly testable disease states and infections for sure. So C. diff, symptomatically, diarrhea, very, very severe diarrhea, cramping, potentially pain, and in really, really bad cases, you may get significant amounts of blood coming out in the stool as well. And remember with C. diff that the regular alcohol sanitizers do not work on C. diff. So if we've got an outbreak of C. diff in a hospital, healthcare type institution, that can be challenging because those spores for C. diff can last and hang on forever. So I've definitely seen that question come up too, as far as an infectious disease question, and those spores from C. diff. With medications, the broader spectrum, more frequent use of antibiotics a patient has, that can raise the risk of encountering C. diff. It really allows C. diff to multiply, replicate, and flourish in the gut, where we've maybe destroyed and killed a lot of the normal flora that maybe prevents growth of C. diff and the overgrowth of that particular bug. PPIs can or maybe have been associated with the risk of C. diff, so that's an important thing to take a peek at as well, especially in patients that maybe have recurrent episodes. Treatment, so drug of choice here is now vancomycin oral, and with that, there's maybe been a little more resistance to Flagyl and that type of thing. That is a potential, second or third line agent if vanco is not successful. Another agent you might see is fidaxomicin or Difficid, and that's kind of along the similar classification as the rifampin type antibiotics, but it is a little bit different, certainly. So again, vanco's kind of taken over as the top dog or the first line recommended treatment at this point in C. diff. Now, H. pylori, major cause of GI ulcers. I think as pharmacists, we recognize medications can cause stomach ulcers, particularly NSAIDs being probably one of the most common medication causes. Maybe, higher dose corticosteroids can cause that. Maybe something like a bisphosphonate, like a Fosamax, can cause that ulceration risk as well. But H. pylori is a major cause of stomach ulcers as well. And for whatever reason, this bacteria has developed mechanisms to kind of shield itself, create a buffer around itself to really tolerate that acidic environment of the stomach and be able to grow up within that environment. As far as symptoms, it's probably kind of classically GI ulcer symptoms where you might have that burning, that pain, GERD type symptoms, potentially weight loss, and that can go along with that as well. Treatment course of H. pylori is usually 10 to 14 days, and there are kind of multiple different combinations, regimens that you might see used here. I listed just some of the main agents that you might see used. So amoxicillin, clarithromycin's got a lot of 3A4 interactions, metronidazole, bismuth, and tetracycline. As far as combinations, I would recommend maybe remembering a few of these at least. So bismuth, metronidazole, tetracycline, and a PPI all together for the treatment of H. pylori. An alternative regimen would be something like amoxicillin, clarithromycin, and a PPI, and that's classically the Prev pack, where we've got Prevacid in there as well as the PPI. But certainly you can use amoxicillin, clarithromycin, and omeprazole. There's really no specificity as far as which PPI to use there. Another potential alternative regimen, clarithromycin and metronidazole with omeprazole. So remember, OAC and MOC are kind of alternative regimens in the event that the bismuth, metronidazole, tetracycline, and PPI don't work that way. So resistance, that's a consideration. Has this person had H. pylori? What regimen did they try in the past? Okay, and if that regimen worked, great. And that was 2 years ago, 5 years ago, 10 years ago, if that worked, well, yeah, then certainly you could maybe justify redoing that regimen. If we tried that a month ago and they're still having problems with H. pylori, certainly we're going to want to mix up and change the antibiotics. So you might switch the bismuth, metronidazole, tetracycline to the amoxicillin, clarithromycin. Okay, getting different agents involved there in that case of resistance. And then, of course, always, when you're asked a test question, don't forget about allergies. Look at allergies. I've definitely made that mistake where I haven't looked at their allergies, and it's bit ya. Meningitis, very severe bacterial infection. In a case scenario, you may be presented with a severe headache, neck stiffness, and a big spike in temperature. So these are kind of classic symptoms of meningitis, along with some of those CNS changes. Okay, so definitely remember those symptoms if you happen to be presented a case that it could be an infection and maybe meningitis. Particularly the stiff neck and headache seem to be kind of associated with that. Likely causes of meningitis. So as far as our management treatment goes, it's going to be guided based upon the bugs that normally occur, and the bugs that normally cause meningitis are different kind of in each age group. So newborns, we've got group B strep, strep pneumo, listeria. Younger children, we've got strep, Neisseria meningitidis potentially. In the teens and adults there, Neisseria meningitidis is one that we probably have the most concern about. We do have a vaccine for that, so that's important to remember. Older adults can be maybe a little bit of a bigger list of bugs that could contribute or cause meningitis. So medication selection. So definitely remember third-generation cephalosporins. Remember, we're looking at situations where we've got good coverage, maybe using more broader coverage type situation. And third-generation cephalosporins are going to cover those gram-negatives, so that's good. And likely have some coverage on gram-positives. Ampicillin is definitely an add-on for neonates, helping to prevent and treat a group B strep. And if you think about meningitis, you've got to think meningitis is a severe, life-threatening type situation. And this isn't the time to really hold back and be cautious on antimicrobial stewardship, okay? So you've got to remember to look at that patient clinically and assess, holy cow, this is a life-threatening situation. We need to make sure we're covering our bugs. Gentamicin's got good coverage for listeria, so you may see kind of various combinations here. Younger kids, so that was kind of neonates we were talking about first there. So younger kids, again, kind of the third generation cephalosporin, so that's going to be kind of a reoccurring theme a little bit there. If we've got strep that we're worried about, maybe resistance due to them being in a healthcare setting, or maybe other family members that have been sick with a resistant bug, or some sort of association or recognition of resistance. Maybe they've been on a lot of recent antibiotics as well. We may have risk as far as being resistant to the penicillin type antibiotics and things like that. Very, very important to remember vaccination. So Haemophilus influenzae and Streptococcus pneumonia, both those, we've got vaccines in kids that can help prevent those issues from happening, or at least reduce the risk, I maybe should say. Young adults, teens, Neisseria meningitidis, have to remember that. Ceftriaxone and ampicillin or potentially fluoroquinolones as alternatives there. You may see prophylaxis be necessary for patients in close contact with that patient who developed meningitis. And again, I think I kind of mentioned this before, but dorms and military type situation where you've got close sleeping quarters and close proximity to others. Elderly, you may have a little bit more likely for strep pneumoniae species that are resistant to kind of your typical classical cell wall inhibitors like penicillins and cephalosporins. So may have a little bit more justification here for vancomycin. Other risks, other things that are kind of associated with meningitis, CNS issues. Lyme's disease is a potential cause. Definitely remember doxycycline as the treatment there. Kind of a unique infection. It's Borrelia burgdorferi, I believe it's how it's pronounced, is the bug that causes Lyme's disease. And prophylaxis, as far as talking about those patients in close contact, particularly maybe those younger adult type patients in dorms and things like that. Rifampin, potentially quinolones might be an alternative there as far as prophylaxis. Sinusitis, very common problem. Most cases of sinusitis are viral, so very, very important to remember that. With sinusitis, I think most people recognize the signs and symptoms there. You got that pressure in the face, right around the nose region, kind of into the cheek region, potentially, maybe up into the forehead, where all those sinus cavities are in the head. Differentiating, again, this is probably more so on the side of a physician and or nurse practitioner, PA, assessing medically these patients. But you will get patients that present to you, whether it be in an outpatient pharmacy, maybe in a clinic, wherever you work, you may get patients that say, oh yeah, I think I've got a sinus infection. Well, some things to think about, some things to look at is, how long has this been going on? Okay, the patient tells you it's been going on 2 days. Well, that's probably most likely due to a viral infection. I would maybe hold off on going in. Okay, so other thing we can look at is fever. Okay, we've got a fever of 103. Yeah, I'm pretty concerned about you. Maybe you better go on in and get assessed and make sure that it's actually bacterial sinusitis and not something else going on. Another sign or symptom is potentially this, nasty, really thick, purulent discharge. And again, usually that's over a longer term course, 3, 7, 10 days plus. And another kind of thing is almost kind of this feeling of rebound, sinus pressure or rebound issue where, maybe the patient notices it right away, maybe it's something viral going on, or that's what they think, and they start to feel a little bit better, but it doesn't completely go away. And then we kind of get this re-eruption of significant facial pain, sinus pressure, that type of thing. So that can maybe be a little bit stronger indicator that it is bacterial. Management, so Augmentin, first-line agent there. Alternatively, doxycycline. Obviously, we got to remember to assess pregnancy in patients, particularly, obviously, younger females. We definitely have to ask that. Respiratory fluoroquinolones, we really want to avoid these in what are considered less significant infections in a sinusitis. Macrolides you may see used, but generally these are at this time now discouraged due to increasing resistance amongst azithromycin and other drugs in that class. Supportive care, NSAIDs, nasal steroids, nasal saline, decongestants, antihistamines. Yeah, I think I talked about most of these quite a bit in the allergic rhinitis section, so I'll refer you back there. Otitis media, so infection of the middle ear here. So this is another challenge where, just like sinusitis, where viral infection is common, and it is common in pediatrics. So many of these patients should not be treated with antibiotics. But if you are a parent, if you've ever been a parent of a younger child, this is really, really hard, and it's a challenging thing to try to figure out if it is a viral infection versus a bacterial infection. So as far as an ear infection goes, some of the signs and symptoms, tugging on the ear, obviously pain, screaming, and depending upon the age, if you've got a 5-year-old, yeah, they can tell you that their ear hurts. If you've got a 1-year-old or a 6-month-old, that gets a little bit harder to tell if it's teething, if it's an infection, or what's going on. So again, as pharmacists, we typically don't worry about the diagnostic side of things, but I think certainly keeping in mind if you're presented a case and patients asking you what they should be doing, recognizing some of these clinical characteristics is an important thing to do. Are they pulling on their ear? Are they screaming in pain? Is it the worst that you've ever seen them? How high is that fever spiking? Are we talking 102, 103, 104? Yes, then, definitely refer those patients on. How long, how many days has this been going on? Oh, it's been going on for about 6 hours, that they've haven't been sleeping and they're just kind of fussing a little bit. Well, it's like, yeah, it could be teeth. It could be a whole bunch of different things there. So, depending upon the severity, depending upon what's going on, encouraging watchful waiting versus treating with an antibiotic. It is a tough call for sure, but recognizing the severity of some of the clinical symptoms is an important thing to do in part of our assessment. Risk factors are another thing we got to think about here. So daycare, infants and toddlers are at higher risk for ear infections just simply due to the anatomy and the small size and the angle of the ear canal compared to adults. Seasonal, we tend to get more of these infections in the fall and the winter, where we're maybe enclosed, we're maybe in schools, and maybe in and around bugs a little bit more that way. Secondhand smoke, asking if their parents smoke, and non-breastfed infants might have a little bit higher risk too. So I think just good things to kind of remember and think about if you are presented a case, and maybe what are some of those risk factors for an infection, an ear infection. Bugs that you got to remember: strep, Haemophilus, Moraxella, that's MCAT, H-flu, staph and strep. Those are most common there. Management, we do have to remember infections. So if you've got streptococcal, pneumococcal type bugs that can cause ear infections, that vaccination can help reduce that risk. Again, kind of watching and waiting if we've only got mild symptoms. If there is an active infection going on, drugs of choice, definitely remember this. Amoxicillin and cephalosporins are usually the first line agents there, along with azithromycin. Again, look at those allergies. Can't stress that enough. If MRSA is suspected, you may see clindamycin and or Bactrim utilized in that setting. But again, that's a pretty rare situation that we're going to recognize and think MRSA is causing the ear infection. Quinolones, tetracycline derivatives in kids, avoid in the majority of situations. Pneumonia, this can often be a very challenging thing in our very young and very old, maybe particular. Pneumonia can definitely impact quality of life, and honestly, it is something that can end life in a lot of geriatric patients. So strep pneumoniae, H-flu, Staph aureus, MCAT. So that's kind of similar bug profile to the ear infection. Rarely we get some atypical bugs, Legionella and Mycoplasma. I think this is important to remember as far as assessing maybe geriatric patients or adult patients for pneumonia. The CURB 65 criteria, so confusion, urea, elevated respirations where they're breathing really quickly, hypotension, another potential factor that might come into play as far as that patient being at risk of maybe not doing so well out in the community, as well as older age. Vaccination, I've talked about that plenty. I've got a whole vaccine section, so I'm not going to talk too much about that here. Healthcare-associated pneumonia, we have got to think about, has the patient used a lot of antibiotics lately? Have they been in the hospital lately? Are they in a long-term care, maybe even assisted living type setting, where we're surrounded by people that are generally on higher numbers of antibiotics and encountering some of these bugs that are highly resistant to antibiotics. MRSA, we have to be aware of that. Pseudomonas, we have to be aware of that. And some of the gram-negatives are becoming more and more resistant as well. As far as your kind of standard community-acquired treatment, so selection of these agents is going to be weighed a little bit upon some of those risk factors, and maybe what medications have they been on recently, and severity of how severe we feel that pneumonia is. So we may use a macrolide. We may use a macrolide with a beta-lactam like amoxicillin. You may see doxycycline as a potential good option for pneumonia as well there. And as we kind of go down the line, the respiratory fluoroquinolone like levaquin definitely is a little bit bigger, broader gun that you might see more so in a hospitalized type patient. Those risk factors I kind of mentioned. Immunosuppression is another good one to think about as far as the risk of resistant pathogens. Antibiograms are potentially a lifesaver as far as recognizing resistance patterns and whether drugs may or may not be appropriate. I wouldn't strongly suspect you'd be asked a question about antibiograms, but keep in mind, just have a good memory of what one is, where basically it tells us which bacteria are prevalent in our community, which bugs are infecting people, and of course which bugs are resistant or highly resistant to which antibiotics. Because if we find a bug that's got a 50% resistance rate to an antibiotic, and let's say that antibiotic is levaquin, and we give them levaquin, that's not a very good success rate potentially for that infection for that patient. So just some things to think about in antibiotic resistant and resistant pathogens. Coverage for Pseudomonas, important to remember that. Ceftazidime, Zosyn has good coverage, Cefepime, and the penems, minus ertapenem. MRSA, vancomycin, linezolid, you're probably going to be looking at. Do not use daptomycin. Daptomycin does cover MRSA, but it is not effective in pneumonia. If we have concern for multi-drug resistant gram-negatives, you may see respiratory fluoroquinolone and or aminoglycosides added on to some of these regimens as well, just in the situation where we don't know what's going on. Again, clinically, we're also going to be guided on, is this a life-threatening situation? If it's a life-threatening situation and we're doing empiric therapy, we're probably going to try to do bigger, broader coverage because we want to make sure that we're resolving that infection if the patient is close to dying or closer to death than living. Outpatient, multi-drug resistant organisms, MRSA. So a couple of options here, oral options. Vancomycin IV infusions, not generally something you're going to see outpatient, but certainly home infusion in certain settings, we may see that. But we do have some potential oral options. Bactrim, clindamycin can have some effectiveness against community-acquired MRSA. And then, of course, linezolid as well there. In Pseudomonas, you may see quinolones used as a oral option in that setting. Intra-abdominal infections. So I think I kind of covered this a little bit within the GI surgery prophylaxis, and I think it's good to kind of lump those two together, where in the gut, we can have gram-negatives, we can have anaerobes, we can have lots of different bugs in the gut. So you definitely have to think about that, in that we need probably multiple angles of coverage and maybe bigger, broader spectrum agents depending upon the severity of the infection and what's going on. So as far as the bugs, we've got those gram-negatives, we've got those anaerobes, and we've got gram-positives as well, like streptococci and enterococci. So if we've got a lower risk type of GI infection, you may see agents used alone, like Zosyn. Again, that's kind of going to cover bigger, broader spectrum, where it can cover a lot of different bugs and hopefully help alleviate that infection. You may see it combined with, or you may see a combination of metronidazole and a third-generation cephalosporin, or maybe even a first-generation cephalosporin, depending upon what we're thinking there. And that metronidazole, again, is really, really good for anaerobic bacteria. Definitely a test question I've seen come up. And, ceftriaxone, cefazolin, those definitely have decent gram-positive coverage. Cefazolin, not quite as much on the gram-negatives, but ceftriaxone certainly would. Quinolones definitely have, good broader spectrum coverage, especially against those gram-negatives. Severe infections, we get definitely more aggressive with broader spectrum agents. So you may see penems used here. These are one of our biggest guns we have. Piptazocin you may see utilized there. Flagyl plus, some of those broader spectrum agents I mentioned, cephalosporin, third generation cephalosporin or quinolone. And if we've got potential for a healthcare associated infection, some of those resistant bugs, if we're worried about MRSA, we might have to add vancomycin or linezolid. If we've got, remember I mentioned enterococcus with GI infections, if we've got vancomycin-resistant enterococcus, or if we've got risk for that, then we've got to do linezolid or daptomycin. Skin and soft tissue infections. Gram-positive bugs are going to be top of the list here, staph and strep. Also rarely may see Pseudomonas as well, maybe in that patient that's more involved in the healthcare system. Maybe they've had a lot of antibiotics lately and, like I said, been in that hospital. Cellulitis, that's a skin infection. Most often simple cellulitis caused by beta hemolytic strep and or MSSA, which is methicillin-sensitive Staph aureus. So here, with those gram-positives, and we don't have MRSA, we can get away with our pretty simple beta-lactam antibiotics. So first and second generation cephalosporins like Keflex, penicillin antibiotics, clindamycin as well has pretty good gram-positive coverage. Now, if we've got Pseudomonas, we're probably going to lean towards quinolones. Again, you want to look and assess the risk of that patient as well. If we've got cellulitis that's potentially progressing to a sepsis type situation where a patient is getting very much closer to being in a life-threatening type situation, we may go to some of those bigger guns and meds that cover those highly resistant bugs. For MRSA in the inpatient side, certainly vancomycin, daptomycin, linezolid. For MRSA in an outpatient basis causing cellulitis, you may see Bactrim and or clindamycin used in that setting. Tetracycline also might have a little bit of coverage for MRSA as well. Animal and insect bite, I think I mentioned Lyme's before, as far as could cause some CNS and meningitis. I did want to mention dog and cat bites. That's one I have seen come up on tests. Pasteurella multicida is the bug there. And again, very similar to Lyme's disease treatment. Endocarditis. Typically with endocarditis, these bugs, bacteria, are seeded usually from other areas of the body into the bloodstream, and then they stick in the heart and can cause an infection there. And that can be from surgery, a wound, IV drug abusers, dental prophylaxis, which is why we do sometimes those dental prophylactic agents like amoxicillin, clindamycin's an alternative there in the setting that they have an allergy. But you've got to remember with endocarditis potentially the source that this bug stuck into the heart from. So most commonly, you may get it, from the skin and that site of entry, and going to the heart and sticking there. So staph and strep are going to be high on the list. Enterococcus is another possible one. Less commonly is gram-negative. So empiric therapy. Endocarditis is usually a pretty severe infection, pretty serious infection involving the heart, obviously. So we're probably going to want to cover for MRSA, methicillin-resistant Staph aureus. Remember, gram-positives are most common, staph and strep, so we probably want to make sure we're covered there in empiric. If we've got recognition of what that organism is, and we've got a MSSA causing this endocarditis, well, then certainly we could switch and go back to a beta-lactam type antibiotic. So again, given the severity, giving an empiric where we don't really know what's causing it, we'd rather err on the side of being overly aggressive and using maybe some of our bigger agents initially until we've got ID and figure out what's going on. So specific targets, MRSA, talked about that. MSSA, talked about that. Gram-negative, again, kind of your third-generation cephalosporins like ceftriaxone, and aminoglycosides like Gent and Tobra potentially. Prophylaxis, this is always kind of a hot-button question issue. Who's a candidate for a prophylactic antibiotic with like a dental procedure or a knee replacement, for example? And some of the things that you need to think about, and generally as a pharmacist, this isn't our call as far as whether we feel they need dental prophylaxis, but I think it is good to think about patients that might be at risk. If you know a patient who's had a heart infection, endocarditis before, that's a potential at-risk patient. If somebody's got a valve replacement or maybe there's higher risk of bacteria sticking and being seated there, that's maybe a higher risk patient. Other pre-existing cardiac injuries, transplant patients where maybe they're immunosuppressed, or heart transplant patient potentially, that's a potential risk as well. And I think I mentioned amoxicillin or clindamycin is usually used in that setting. Again, look at allergies. Osteomyelitis. This can be a really tricky infection to treat. So kind of along with bacterial prostatitis, osteomyelitis often has a length of weeks of treatment with antibiotics. So this is an infection of the bone, redness, swelling, pain at the site. That can certainly all happen, as well as that spike in fever. As far as, what contributes, what causes this, diabetes is a risk factor. Remember, as those blood sugars go up, infection risk may increase there. Immunosuppressed patients, certainly. Illicit drug use, where we're seeding bacteria, putting bacteria into the bloodstream, where maybe that bacteria stops on the bone or near that bone area and creates an infection. Also, probably one of the biggest risk factors is recent surgery or trauma. So if you've got a patient that's got a really complex fracture where maybe it was horrible and their bone was sticking out of their leg and that type of thing, just a really nasty fracture, that's a potential risk where bacteria could be seated there and they may be at risk for developing osteomyelitis. As far as there are medical procedures where we, remove that nasty skin, try to improve blood flow, and if osteomyelitis gets severe enough and we don't have adequate perfusion, which can happen in our diabetic type patients or those with PAD, peripheral arterial disease, or peripheral vascular disease, where that blood flow is poor, amputation is always a concern there with a osteomyelitis infection or a infection in general. Bacteria, so cultures are very important here. Most commonly, it's some of those bugs on the skin, like staph, causing an infection there. So, again, in a severe type situation, we maybe err more on the side of covering some of those resistant type bugs. If we've identified what that culture is and what the bug is, we can really hone in and target it. So if we've got an MSSA, for example, we can maybe use one of those beta-lactams. If we've got gram-negatives involved, quinolones is often an antibiotic that's used there. Again, these are challenging infections to treat. They definitely take weeks of therapy often. Antibiotics, kind of covered this a little bit. Penicillins, Clinda, good for those gram-positives for sure. Bactrim, you may see utilized, may have some activity against MRSA, and possibly some gram-negative activity there too. Rifampin can be utilized to prevent reinfection. That's something you might see. And Vanco with MRSA, linezolid, same thing. And quinolones on the gram-negative side of things. Sepsis and septic shock. So this is a life life-threatening type situation. So that's always kind of kept in the forefront of my mind, that we would probably err on the side of being aggressive with bigger, broader spectrum antibiotics, particularly if we have no clue what bug is potentially causing this bacterial infection of the bloodstream. Signs of sepsis, so we've got fever, tachycardia, really fast breathing, tachypnea. In severe sepsis, we do have a lot of potential for organ damage, and we kind of have potential for lack of perfusion. We've got changes in that urine output, can impact the kidney, can impact cardiac output, as well as respiratory failure and respiratory difficulty. Again, kind of depending upon what's going on and where things are happening. Septic shock is signs of sepsis, which I kind of talked about earlier with the fever and temp and so on and so forth. Septic shock is that significant drop in blood pressure along with those signs of sepsis. So big drop in blood pressure, and we're not getting any response from replacing fluids. Okay, so important to remember there. And we do have some risk factors, some things that might increase the risk of septic shock, like elderly, multi-drug resistant bacteria, and immunosuppressed. So with sepsis and management, we definitely want to get antibiotics on board and do it as quickly as we possibly can. And we want to try to identify what might be that source for infection. That's really going to help guide us for antibiotic selection. Getting those cultures going is important as well. Fluid replacement, particularly in that setting where we've got that drop in blood pressure. And if we've got situations where we've got really low blood pressure, they're not responding to fluid replacement, vasopressors may be considered here. Did want to mention the vasopressors here quick. Norepinephrine, Levophed is the brand name there. This is generally considered to be first line. It's got alpha agonist activity, so it's really going to help clamp down on those vessels to raise that blood pressure and manage that hypotension. Dopamine may see utilized, epinephrine more so in anaphylaxis type situation due to severe allergic reaction and that type of thing. But norepinephrine is usually going to be first line in the setting we're talking about here. Antibiotic selection. Again, we got to think about all bugs that may be at play. Look at resistance patterns, antibiograms, and again, the people that work in these settings are usually going to be on top of that and recognize what's been going on there. And from that source, hopefully we can get a sense. And if you think about some of the bugs I talked about in the previous disease state lectures, so skin and soft tissue infections, we got to be thinking gram-positives. If they've recently had a UTI and now they've gone septic, we've got to think maybe more so along the lines of gram-negatives and so on and so forth. So that kind of wraps up that sepsis type situation. Again, I wouldn't focus too much on the acute care management, but just recognizing some of the potential bacteria, the MRSA, the Pseudomonas, things like that, and what bigger, broader spectrum agents you might use to cover those. And I've got another section on multi-drug resistant organisms too, which I've kind of alluded to as I've talked through here. So I want to move on to tuberculosis here. And with TB, the signs and symptoms, probably the biggest sign and symptoms is cough and weight loss with TB. So it's this kind of chronic, ongoing cough that lingers and lingers and lingers. It can be very, very severe. And if you think about a chronic cough, how physically taxing that can be. If you've ever had a head cold where a cough has lasted for a while, TB is like that times 10, where that cough just goes on forever and ever and ever. Can have some fever associated with it, obviously some tiredness, fatigue, and in the more active stage, it is definitely contagious. In the latent stage, which is kind of that period of nothing going on, but we still have the infection, that isn't contagious in that latent type phase. I do have a link to the guidelines there from the CDC. I wouldn't spend a lot of time worrying about tuberculosis and different lengths of therapies and treatments. I would focus on kind of the agents that are used, and that's what I've got highlighted here. First, I did want to mention the immunosuppression risk in TB. So most younger, healthier patients with good immune systems, this infection will be suppressed. But in patients that are immunosuppressed, you may see TB kind of rear its ugly head and kick up with the fever and the coughing and all those symptoms that I mentioned earlier. So like I mentioned, focus on, I would say, more so the drugs and the potential for adverse effects and that type of thing versus the length of therapy and the combinations and all that sort of stuff. I would definitely focus more so on drugs and adverse effects possibilities. So with that, isoniazid, have to remember liver toxicity. It's definitely a hallmark thing with this medication. There is a possibility for neuropathy as well. You may see pyridoxine supplemented, which may or may not be helpful, kind of depending upon the patient there and the whether they've encountered this side effect. Rifampin is potentially used in TB management treatment as well. Remember all the drug interactions with that. Ethambutol, more liver function problems there. Basically, remember that for all the TB drugs, that you're probably going to want to monitor liver function. Rarely with ethambutol there is some eye trouble, so definitely remember routine monitoring for that. Pyrazinamide, uniquely it can exacerbate gout, and like I mentioned, that liver function monitoring is important with all these drugs. So those common drug-resistant bugs, I kind of alluded to that in sepsis and kind of thinking about what you need to cover and that type of thing. MRSA, I've kind of covered this throughout, but just kind of highlighted on the slides a little bit here. So in community-acquired MRSA, doxy, clindamycin, Bactrim are probably going to be your main options there. And avoid penicillins and cephalosporins with MRSA. Inpatient meds, vancomycin and daptomycin definitely have good MRSA coverage. Strep pneumo, you may see some resistance here with this particular bug. Avoid in the setting of resistance, a resistant strep pneumo, definitely avoid again penicillins and those simple cephalosporins, first, second, and third generation. Alternatives: levofloxacin, moxifloxacin. Cipro's not really considered to be good as far as respiratory fluoroquinolone, so typically avoid that one. Clindamycin and certainly Vanco can be an option there as well. VRE, I think the name says it all, avoid Vanco. And there we've got linezolid and daptomycin as alternatives. Pseudomonas, you got to remember Zosyn, that's commonly used for Pseudomonas. Levofloxacin, the quinolones are sometimes used for Pseudomonas. That's obviously a decent option on an outpatient type basis where we can give oral quinolone that way. Meropenem, colistin, polymyxin B are other potential options, probably used less commonly. Ceftazidime does have some activity as far as Pseudomonas. Cefepime is another one one of the cephalosporins that may have some anti-Pseudomonal activity as well. But again, with Pseudomonas, definitely remember the majority of cephalosporins are resistant. Other particularly troublesome bugs, I didn't talk about these too much kind of throughout the different types of infections, but Klebsiella definitely can be one that produces some ESBL, so these are extended spectrum beta-lactamases, and these are resistant to things like the broader spectrum cephalosporins, like third generation cephalosporins. So alternatives here might be a Penem or Colistin. With E. coli and those ESBL type agents, these can show significant resistance to Bactrim, those cephalosporins, and sometimes quinolones. And in those type of settings, you may see nitrofurantoin used. So this is more of a UTI type situation in the event that it's sepsis or something else going on due to that ESBL producing E. coli, or that E. coli producing ESBL. Penems are going to be more of a drug of choice there.